This is a rule of Corvus. If you look at the Corvus, you can see that the CBI and TBI and a lot of biomechanical indices are normal. So this is not a keratoconus. But what about this steep area here? If you look at the OCT, you can see that there is some epithelial hypertrophy due to contact lens wear. So this is just an artifact. So this is not a keratoconus. Another case of inferior steep area, as you can see, with no prominent steepening in the elevation maps or thinning associated. You can see that the bad display is normal. But if you do Corvus, you find that the CBI and TBI is affected. So will you believe Corvus or not? You look at the other eyes are frank keratoconus. So Corvus is right in diagnosis of this case.
Is there a difference between the machines يعني اللي هو available in Egypt, for example, most commonly Pentacam, Oculus, CSO. Sometimes you have something in the Pentacam telling you this is the keratoconus, and you do the CSO, it's normal.
Definitely, there are a lot of differences between machines, and even sometimes between the same brand. If you do Pentacam somewhere else, it will be different than in another place. So the recommended thing is to stick to one machine and take decision based on one machine. And if you are going to use more investigation, you should go for alternative technique like epithelial mapping, biomechanical evaluation. But still, even for follow-up, it's very important that you have like a patient who's done Pentacam in Upper Egypt, for example, and after crossing 3 years later, he came to me and he's looking for progression. I can't detect progression well because he's doing Pentacam in different places. So you can't detect because if you have different scale, different capture, and a lot of factors. So you can't trust your own machine. This is the end point. Another dilemma I would like to highlight in it is a thick flat cornea with posterior elevation. أنا محمد عبد الوهاب طبعا يعني he's one of the pioneers in optometrist in Egypt, and he keeps sending me cases like this diagnosed as keratoconus, posterior keratoconus. As you can see, there is an island here that is suspicious, but still it's a very thick cornea with flat cornea. There's nothing here except the posterior elevation, and if you have a holiday formula, you can see that this area is prominent here, but still there is no other clue for keratoconus, and even the bad D is affected by the elevation here. This is the solution for this case. This is a case of flat, thick cornea with shallow AC. The shallow AC will give you an artifact of posterior elevation. This is not a posterior keratoconus. Another exaggerated case, very thick cornea, as you can see, over 600 microns, flat cornea, 40s, 40, I mean 40, less than 41 even, with posterior elevation here. Still, you can have a look on the anterior chamber, very shallow AC, 2 millimeter internal. So this is not a keratoconus, this is another entity that can cause some sort of confusion. The PMD, we used to diagnose cases like this as PMD in the past because of the crab flow or butterfly effect. When I was young, I was very happy to diagnose those cases as PMD. But now, after a lot of discussion about the true PMD, it's actually a very rare cases you can find. This is a case that you can diagnose as PMD, but actually this is just an inferior keratoconus. Look at the elevation maps here. And you should look at the shape of the cornea. You can see the pathognomonic pattern of the PMD. Comparing this to this case, it has the crab claw appearance, the same shape, inferior thinning of the cornea, but have a look on this band of thinning, the pathognomonic of PMD, and I call it Kirsch, actually. It appears in after the thinning of the keratoconus, of the PMD. PMD-like keratoconus, what we do for this patient, those patients are suffering from astigmatism, mainly with good Q value, actually, or even oblate corneas. What you will do is implanting one short ring inferiorly, it will improve. This is and those cases are very predictable, by the way. I have done a lot of cases of those patients. I'm very happy when I have a patient with this configuration, because I know that the astigmatism will improve a lot after implanting just one single ring short inferiorly. Advanced keratoconus like this one, this is a very advanced case. What will you do for this patient? Thickness is 263 with Kmax of 81. What will you do for this patient? Is 30, 35, something like this. It's a good question. It's not a clear cornea, actually. It has a superficial scar, as you can see here. No, just superficial scar, as you can see in the pentacle. With this scar, he will not improve. But this is a patient going for definitely DALK or PKB if he is not capable of doing DALK. But this is a classic case for DALK. You don't do cross-linking with the scar. You don't do intracorneal rings with this severe scar, with this very steep cornea. So you will go for DALK. Can you see the biomechanics of the cornea? How weak is the cornea? I call it a dancing cornea. The dancing cornea. So it's very weak cornea. The cross-linking will not be effective in this case, and you can see the scar over the layers of the cornea even deeper than we can expect. Another case, what do you think of this case? This is a case of refer for me for DALK operation. Can you see the steepening here with posterior elevation, with anterior elevation, but the pachymetric profile is not fitting this case. What do you think of this case?
A bad display.
This is a topometric indices, and this is a bad display.
Is there any scar?
Yes, there is a superficial scar, as you can see. What will you do for this patient?
It's not a keratoconus case, so the vision and the affection for the vision from the scar.
The vision is 0.2, so this is not a keratoconus?
Not keratoconus.
Why?
The scar effect.
It's just a scar effect. If you look at this patient, he has this scar located inferiorly, and this is why this patient was referred for DALK operation. But actually, if you look at this scar with a bluish gray color here, it's talisman nodular degeneration. So what I did for this patient is just scrape it. And you can see that if you scrape it, even the Bowman membrane might be normal. Just remove it. I call it with a Rixus maneuver. So you will end up with crystal clear cornea. There's nothing. I will stop here for the live surgery case. I will present it before I go to the Watani Eye Hospital. And I think we'll have the presentation with Dr. La'ani after the coffee break. So you will have time before doing the live surgery. And meanwhile, we'll get ready for Dr. Hafizi, because he will join us after 10 minutes. We'll start with Mrs. Nikki Hafizi. So thank you for your kind attention.